I'm Jason Wallen, co-host of Brain Buzz. I'm here with Dr. Chris Rayo, Chair of Emergency Medicine for Good Sam and Chief of Emergency Medicine for Catholic Health.
Yes.
So all-encompassing emergency medicine. And one thing I think that is exciting, especially at Good Sam, is the addition that we're having of the new emergency room.
Absolutely.
Can you give us a little more insight into that?
Sure. So we see about 90,000 patients per year, as you know.
Yes.
So a fairly busy place, and we have a lot of services in the emergency department, including a separate dedicated pediatric ED, multiple teams of physicians, an observation unit, and to be honest, we've just really outgrown the space. So we're very excited to be opening a brand new emergency department in the new patient care pavilion, which hopefully will open towards the middle of next year. And what that's going to do is really just match the environment with the outstanding care that we provide. As you know, we have some of the best clinical services really anywhere in the country or the world, from stroke to cardiac services to trauma. And the environment sometimes doesn't always match that, just because we've sort of outgrown the space. So some of the key features in the ED are private rooms. So everyone will be in a private room, which not only will make them a little bit more comfortable, but as you know, the quiet nature is better for healing, etc.
Absolutely.
Catholic Health's Neuroscience service line is right now in really growth phase, and there's a lot of things happening in the area. So the first thing I would say is Neuroscience becoming a service line and becoming a department at Good Samaritan Hospital is something that's imperative, as Good Samaritan Hospital is really looking to become the Neuroscience Institute for Catholic Health and really be the hub basis for Long Island. So that's one of the first things. And you guys, you and Dr. Bekelis have done an amazing job at Good Samaritan, and that's why we're really highlighting the good work. We don't want to recreate the wheel. We want to highlight what you guys have built and stand it up even further. And then from there, what we're doing, which is the next piece, I think, which is really interesting, is we're really taking what you guys have developed at Good Samaritan Hospital, and we're really looking to extrapolate that and move that to St. Francis Hospital, and have St. Francis Hospital really become what Good Samaritan is in Suffolk County in Nassau. So St. Francis will have just as great neuroscience and neuroendovascular care, neurointerventional care as Good Samaritan, because we're taking what you guys built, the training and the experience, and really transplanting it there. So I think that's super exciting. I think it's an amazing platform for you guys' continued growth, but for Long Island in general. I mean, I think we're about to serve the entire basis of Long Island with the greatest care that we can provide for this, for all of our patients.
The web device was the only thing that was available in the US, and as you're aware, in Europe, things come out multiple years before. And Europe had 3 or 4 intrasaccular devices. Last year, the Contour device was actively being developed in its final stages and going through the clinical trials, and now that's Stryker now has that as part of their repertoire. So that's really going to give us another device to use. As with all of these, I mean, when you look at it, you got to wait for the long-term data, right? Endovascular, that's always what we worry about. Recanalization, what's it look like at 3 years? Coils, that's our hallmark of what we do. It's our foundation stone for treating things is with coils. Even then, you do it, but you get coil compaction, so you have to look out and see what happens. And I think these things are the same, but I think they show great promise, and the fact that it's really this one and done phenomenon where you don't have to put multiple coils in, you just get it situated correctly. And both Webb and Contour kind of work on a flow diverting principle where they endothelialize. If they stay in place, they endothelialize and help to rebuild the vessel wall. So they're an intra-aneurysmal flow diverter, essentially.
I mean, idiopathic intracranial hypertension.
Okay.
Yeah.
Can you just give us a couple quick bullet points on that?
Sure. This is a common problem, more common these days, than it has been, and it's something that happens and afflicts women of childbearing age most often. Women in their 20s, 30s, and 40s. And it's an alteration in their CSF fluid dynamics, and where essentially the pressure in their brain goes up, and they get headaches and tinnitus, pulsations in their ears that can be really aggravating and intractable. And then ultimately, if it's not left untreated, they can lose their vision. And I think it's something that we're trying to raise awareness on, because I think if patients can get to medical attention early, we have lots of tools in our armamentarium: weight loss, medications, surgery, venous sinus stenting, which is the new techniques that we've been pioneering.
Yes.
To reverse these problems and give them a full recovery.
What does the future look like to you in terms of what are new procedures that we will be doing? How are we going to be changing neurointervention coming up? I mean, of course, we have some inklings with the new trials, but of course, you have a lot more insight than most of us.
So I think the future of neuroendovascular, I think, is more indications, and I see it in 3 major fields. Intra-arterial therapies, I think this is a field that it's gonna grow a lot. So, for example, intraarterial chemotherapy for malignant brain tumors, targeted therapy for brain tumors. We already do the intraarterial chemo for retinoblastoma. So all kind of intraarterial therapies is something really important. Now, another field is the venous disease, and we saw this the last 2 to 3 years, the venous disease indications, for example, idiopathic intracranial hypertension, and all other venous procedures that we've been doing that we weren't doing 2 or 3 years ago. And I think the third field would be the brain-computer interface, but endovascularly, like, for example, the stent rod for patients that are quadriplegic, where going up intravenously, placing a stent in the superior sagittal sinus and hook it to a battery. So all this field is really going to grow.
St. Joe's is a fantastic hospital, one of our best feeder hospitals, and that is due to, they get the patient diagnosed and right out for treatment, and that is pretty much because of you and all the work that you've done.
Well, I think it's the whole team, but one thing about stroke and why I'm so passionate, like even before Kimon got there, it's still the leading cause of disability in the United States and worldwide. When we talk about how severely patients are what's the word I'm looking for? Sorry. Affected by stroke. It's not just, you don't just look at cause of death, but when you take a look at nursing home related care, getting back to a regular state, even the families that are involved, right? If this is your mother, if this is your father, somebody that's had a stroke, the amount of care that goes into that patient. So that's why it's always been one of the hottest topics for me. I want to be able to serve our community, and we have a lot of sick patients that come over to you guys at Good Sam from St. Joe's. So.
Wow.
So this is our 6th annual conference. You're a big part of the conference, so thank you for all your hard work. What was your talk about today?
Well, I spoke today about posterior circulation strokes.
Okay.
Often a stroke that goes misdiagnosed, but can lead to very significant deficits. So, that's something that's pretty important that can be missed very easily.
Yeah, and you have a different perspective because of coming from nursing. So kind of what people, especially the nursing community, of course we have physicians talking, sometimes they can be a little high level. So it's nice to have, the meat and potatoes of what people need. So that's refreshing, I think.
Yes, and as a nurse, especially a nurse working in the triage in the emergency room, when these patients come in, they often come in with very vague symptoms. So it's very difficult to discern what the patient's complaint is, and if it is truly related to stroke. For instance, posterior circulation stroke patients can come in with a multitude of issues, oftentimes vertigo or dizziness being the number one complaint, and they can also complain of chest pain with this, nausea, dizziness. So it's very hard sometimes for the nurse to decide if this stroke or is this something else going on. But I will say kudos to our emergency room staff. They have a very low sensitivity for activating stroke alerts when these patients come in. And as a result of that, we have had young patients especially end up avoiding what could have been a significant deficit as a result because of the good work that our emergency team does.
A lot of new studies that are opening up new avenues for patient care, which is fantastic.
Yes.
As the newly minute director of Neurovascular, do you have any plans for the next year? Any new visions that we want to enact?
Yeah, I mean, we are happy that there are data which supports what we're doing, so we want to expand our portfolio, being able to provide, patient care on the ICAD, the pathology side, and also trying to get involved in clinical trials, to be part of developing our field. And I think that's happening right now with the new trials coming out, showing benefit for intervention with aggressive medical treatment.
So what is different this year from last year?
There's always new studies coming out. I touch on a few of them. We always got to do the oldies because they're good for comparison. But as we move along in time, we always want to improve patient outcomes, right? It's always about the patient. So how do we reduce time to treatment? How do we plan for better outcomes? How do we meet those metrics? And we do that by looking at the studies and keeping up with the newer stuff that comes out. Newer treatment techniques, different suction catheters, stuff like that.
Things progress every year, you would say.
Yeah, that's some of the discussion that actually was just happening after the talk with some of the docs, was that things are moving very quickly actually, and they change really quick in this world, so you have to kind of keep up or get left behind. And that's one thing that this program is very, very good at, is keeping ahead of the curve and making sure patients do really well.